ventilation perfusion. That might be proning. We want to think about what medications we're giving, and do we increase them or decrease them based on how he's responding. Make sure we're keeping an eye on his cardiovascular status and maintain MAP, even though he doesn't have any cardiac problems. He might have some issues from his increase in PEEP. Help with chest physiotherapy, monitor fluids, make sure that those nebulizer treatments are done. Keep an eye on all of those labs. Make sure we're including the VTE protocol and the VAP bundle, again, GI prophylaxis, making sure that we're incorporating his nutritional needs, and then support and educate the family. Okay, so how are we going to know if we're making a difference? That Mr. Cook wouldn't have any abnormal breath sounds, that his PaO2 and PCO2 would be within normal ranges, or at least at his previous baseline, that he's got a really good cough and that he's actually getting those ooey gooeys out. His respiratory rate would return to a normal rhythm and depth, that he would have synchronous chest and abdomen movement together, that they're not in asynchrony, that he's not using his accessory muscles, that his edema is decreasing, that he doesn't have increased pulmonary artery pressures. Do you remember back to hemodynamics? So pulmonary artery pressures are like kind of the blood pressure in the lung, that we don't want increased pressure. We're going to look at all of his labs, talk about decreasing anxiety, and then using some positive attitudes. So unfortunately, some people will survive, but some people require long-term ventilatory support, and about 50% of those ARDS patients do pass away. So good thing for Mr. Cook, he was on the ventilator for 2 weeks, and then he started to show improvement. He did get a tracheostomy on day 8, and he was transferred to a long-term care facility where he rehabbed for 26 days. So we did a great job, and Mr. Cook did get better. I know we're running short on time, or we're getting short, but we are going to quickly talk about pulmonary hypertension and lung transplants. So pulmonary artery hypertension, just what I just said, is increased pressure in the lungs. So you don't have to know what normal is, but if you have a pulmonary artery catheter or a hemodynamic catheter, it's quarter overdone. So 25/10 is normal pulmonary artery pressure, so you're looking at pressures that are much, much higher than this. And this increase in pressure causes the inability of the cardiac output to respond based to an increase in oxygen demand. So sometimes we really don't know how it happens, and sometimes it's due to some chronic conditions. So these patients look like they are short of breath on exertion. So DOB-OE, they're lethargic and really tired. They don't have adequate cardiac output because, again, it's not allowed to return. They have right ventricle failure due to increased pressure in the lung. It looks like signs of right-sided heart failure. So they have increased JVD, they have weight gain, they have an S3. When you guys are listening to heart sounds, where you should be right now is you should listen and you're like, man, I don't know what that is. But it doesn't sound good, or it doesn't sound right. It doesn't sound normal. That is exactly where you guys should be right now, and what you should then do is say, I need someone who's an expert to come over and listen and tell me what the sound is. So what is the normal S1, S2? Lub-dub, lub-dub, lub-dub. We've got it on all the cardiac lectures. So an S3 is called, we say it's lub-dub-D, lub-dub-D, lub-dub-D. It's an extra sound that comes late. An S4 is actually a sound that comes early. So it's like S4, S1, S2, S3. S4, S1, S2, S3. So these patients that have pulmonary hypertension, right-sided heart failure, have an S3. So really, it's best if we can have early recognition of pulmonary hypertension, and there's really no cure. The cure is to have a lung transplant, but we would do our best for symptom management. So the drugs that we would use promote vasodilation of the pulmonary vessels. They reduce the right ventricular overload and then help reverse any cardiac remodeling that happens. But really, if these patients gone untreated or become very severe, they need a lung transplant. So lung transplants, these patients are at end-stage lung disease. What's really a challenge about lung transplants in particular, this is from stats from 2019. There are 3,243 candidates that were added to the waiting list, but there were only 2,755 donors. So in 2019, there were 59 transplants, and you're like, wait a second, that doesn't make sense with the numbers that you just said. But 3% of those patients were retransplanted. So there's actually, and this is in Texas, by the way. So there's just not a lot of availability. So the lung allocation score, the purpose is to, and this is not something that you need to know for the test. This is just like really good information to find out how patients are listed on the lung transplant list. It's a waiting list based on urgency and what they think the post-transplant survival will be. So they include things like age, BMI, again, those pulmonary artery pressures, if they have diabetes or other comorbidities, what their renal function is, and they do a 6-minute walk test to see how low their SATs go and what their energy level is during that 6-minute walk test. And that's how they decide how well the patient is going to do post-lung transplant. Okay, so before they get their transplant, it's a very extensive evaluation. And what's so interesting is they look at the support system of, they have a very complex post-op regimen that they're on, so they really have to have good family and social system for support. They have to adhere to strict immunosuppressive therapy and then monitor very closely for any signs and symptoms of infection. So we can do a single lung transplant, a bilateral lung transplant, a heart and a lung transplant, or we can transplant a lobe from a living donor. Post-op, these patients, of course, are ventilated, and these are the patients that may have a bifurcated ET tube where you're ventilating one lung in one way and one lung on the other way. Optimizing fluid and hemodynamics, of course, immunosuppression, giving antibacterial meds as needed, nutrition support, and then preventing infection. The preventing infection is the most important thing that you can do for a lung patient receiving a lung transplant because it is the leading cause of death. So if we can detect any signs and symptoms of acute rejection as early as possible, that's going to be helpful for these patients. It's usually within about a week or so after their transplant. They have a low-grade fever, dyspnea, and decreased SaO2. We might get a biopsy to see if they are having acute rejection, and we treat with high-dose steroids and then high-dose IV steroids and then follow up with PO. Those patients in chronic rejection, they really have their airway does not respond to bronchodilators or steroids, and they're really in this chronic rejection state. So the best thing that we can do is detect signs and symptoms of rejection as early as possible. Whew. Okay, questions? Okay, so because y'all are here in class, we have an in-class quiz. So the quiz is only open until 12:20.